So treating bicuspid with TAVR, what does the data say? I think this is a unique situation which where Indian TAVRs are surging ahead with the data globally, because we all know that bicuspid aortic valve is a more commoner phenomena in Southeast Asia rather than in the Western population. So our experience with bicuspid TAVR is much better and bigger than the Western guys. So rather than they giving us feedback, they are seeking feedback from India to deal with the bicuspid aortic valves and doing a TAVR in such subsets. So bicuspid valve classification, it's a Sievers type 0, no RAFE. Type 1, there is one RAFE. Type 2, there are two RAFEs. So this is how it is classified, and we once we see the patient and do the transesophageal echo and a CT, we clearly define that what kind of bicuspid we're dealing with, especially if there is a RAFE which is calcified. That is one scary thing where we need to be careful, because that calcium may impinge upon the aortic annulus and may cause a rupture. So we have to be very careful in selecting a proper case for a bicuspid TAVR. So type 0, as I mentioned, no RAFE, no symmetrically developed cusps, sinuses and commissures. These are 10% of all the bicuspid aortic valves. Type 1 is two conjoined cusps with one RAFE. RAFE orientation determine the cusp involvement. Most common type of bicuspid aortic valve is type 1. So there is one RAFE, and these are the two RAFEs. So it's like this, and this is the least common. So evolution of treating a bicuspid aortic valves with TAVR. Once the TAVR started, there was a lot of statements coming around that bicuspid aortic valves perhaps is not suitable for TAVRs. Initially, everybody was quite cautious about dealing with bicuspid aortic valves, but then the data accumulated, the experience became enhanced, and now we are treating the bicuspid aortic valves quite frequently and routinely in our practice. As the Indian aortic stenosis, they have a lot of bicuspid aortic valves. Incidence and distribution of bicuspid. So this is, as I clearly mentioned, in our practice, almost 50% of aortic stenosis we see are bicuspids. So TAVR bicuspid versus tricuspid, there have been studies, the Gary registry, the results, higher rate of aortic regurgitation after TAVI amongst the patient of bicuspid versus tricuspid. It's quite anticipated because, it's not a centralized valve. It's a erratic, decentralized valve. So once we open a TAVR valve in this pathological valve, we can't really predict that how it's going to open and how the centralization would happen and how it will squeeze the fish mouth valve beneath it. So there are chances that it may lead to more paravalvular ARs. So this is another analysis, multi-center analysis. The results, bicuspid versus tricuspid, obviously anticipated that bicuspid device success rate was lower, AR was higher, and these are earlier results, I would say. The TAVR in bicuspid aortic valve implications are that CT-based sizing helped in considerable decrease in post-AR. So then once we were facing all these challenges, we became wiser how to place a TAVR valve in bicuspid aortic valve. It has to be shallow, or it has to be a zero position at the annulus, not down into the LVOT. So that things actually made us much wiser and our outcomes became better. So I'm not going into the details of all the studies. The issues learned from first generation valves, CT mandatory for sizing and diagnosis, higher PVL rates were there and higher pacing rates. Most studies are small with limited numbers. The breakthrough study came, was this, by Forrest, the patient's bicuspid low risk, and where it was randomized, bicuspid and tricuspid. So valve dynamics, I'm coming to the results. So these are the results. The paravalvular regurgitation for matched patients. See now it's almost matching bicuspid versus tricuspid, not a major difference, which was initially there with the earlier data. The typical problems that one can encounter is sizing, crossing of the native aortic valve, crossing of the TAVR delivery system, and always a need for pre-dilatation. This is how the bicuspid aortic valves can look like. It may be tubular, the first picture, and then it may be an inverted funnel or a tubular funnel. So we need to establish these facts on CT, that how the bicuspid aortic valve looks like. The various schools of thoughts, no guidelines for bicuspid sizing, still not clear. So based on this, very clearly we have to select the size of the TAVR valve. So I'm showing some cases of TAVR and bicuspid aortic valves. See, this is what I'm talking about. Type 0 bicuspid. So the procedure, and then the access is taken from the right femoral, and then see, as I mentioned, it was a severely calcified valve, uh, dilated with 22 millimeter of ZMED balloon initially, and then the evolute R valve. So this is a beautiful valve to deal with bicuspids, as this valve provides the better effective orifice areas because of its supraannular valve sitting in this rim. So bicuspids, the shallow deployment and the self-expanding is better than the balloon expanding. The learning, especially in the borderline case, look at the whole anatomy, including the LBOT. Balloon sizing may be a good strategy for deciding the valve. This is another case why there is a need of pre-dilatation. So bicuspid is an erratic anatomy. To make it better suitable for valve deployment, we should pre-dilate all cases of bicuspid. Again, this is a CT analysis. See, look, this is a funnel-shaped anatomy. So four-step minimalistic TAVR procedure. The gradients taken. Uh, this patient had a moderate AR also. So that is the reason, pre-dilatation was not done. But if there is no AR, we should dilate all the valve. This is evolute R again, and a great result. 30 minutes, 40 minutes for the procedure to be done. So overall, very nice result with evolute R, and I'm mentioning again and stating, emphasizing that self-expanding is better once we are talking of dealing with the bicuspid aortic valves. Case number 3, 72-year-old male patient. Echo showed severe AS. This is the CT analysis. Again, a Sievers type 0. Here it was again heavily calcified. So the valve was actually facing a lot of resistance going across the aortic annulus. So we have to take a buddy wire. So buddy wire means like we take buddy wire in the coronary. So that concept still is here, that one wire, it's not going, and then we take another hard wire into the LBOT. And then the valve went, and this is the final deployment. So some precautions and more meticulous approach is required while dealing with the bicuspid valves while doing TAVRs. One clear instruction is it has to be a shallow deployment, and another is if need of post dilatation is there, if there is a PVL, we should post dilate all these valves. So this is I'm trying to tell that how we should manage, how we are doing. So now with our data increasing, we are almost, I'm personally almost doing 5-6 TAVRs a month. Tomorrow there is one percutaneous transmitral valve replacement also with a degenerated mitral prosthesis. So all kinds of structural, the pace is increasing, the volume is increasing, and this is just a effort to give you a flavor that how structural heart intervention is moving in India. Thank you very much for the patient listening. And if you have questions, we can talk about.